Welcome to ICU Primary Podcast. Hi, my name is Swapnil, and today I'm joined by our co-host, Dr. Mike Clifford from Melbourne. Welcome, Mike.
Thank you, Swapnil. How are you?
I'm good. It's been a long time, and the reason we had a bit of break because everybody decided to take break for various reasons. The good news for all the listeners is Maddie has delivered a baby boy who is doing pretty good. So congratulations to Maddie and her family, and we obviously look forward to getting her back probably in next 3 to 6 months once the maternity duties are a little bit eased out. In meantime, Mike, how have you been and what's your break time look like?
Reasonably good. This is our memorial episode for Maddie's pregnancy, which we'd planned to do a couple of months ago, but we're still planning on doing a shout out to her by talking about the physiological changes of pregnancy. And now that she's had her baby, we can probably do another episode next time about the transition. So let's get on with that.
So, Mike, as you mentioned, so pregnancy has been asked multiple times in the primary exams in the various forms and shapes. So let's start with some of the respiratory changes that occur during the pregnancy, which has been a SAQ and also part of the VIVA. So can you walk us through some of the respiratory changes that happen during the pregnancy and why they're important?
Yeah. Okay. So the reason that pregnancy is there is obviously because we all will look after pregnant women in intensive care. Women are the forgotten component of the syllabus, if you like. They're the one part of the syllabus that isn't the 70-kilogram male at sea level. And the changes of pregnancy are really quite extraordinary, as Maddie would have been able to tell us were she with us today. But when thinking about any of the questions related to pregnancy, you can do it in multiple ways. You can either divide it up into trimesters, the changes that occur, or you can just go through systems, or you can break down the individual system into how you think about it, whether that's cardiac or respiratory. So if we start with respiratory, we'll think about, first of all, the changes to minute ventilation, which is a function of your alveolar ventilation multiplied by your respiratory rate, which is very similar to cardiac output equals stroke volume times heart rate, okay? It's the driving function. And like cardiovascular, respiratory goes up in pregnancy. Makes sense? You've partly got a small parasite growing within you that is generating carbon dioxide and consuming oxygen, and certainly a lot of metabolic fuel, but also is accumulating fat, protein, and carbohydrate stores. So there's an enormous metabolic cost of growing a fetus from a couple of grams to somewhere between 3.5 and 4.5 kilograms, depending on how big your baby is. So with respect to the minute ventilation, it increases, and your dead space is almost certainly a little bit increased, maybe unchanged, but your alveolar ventilation has to increase, okay? And that reduces your PaCO2, and there's a slight increase in your PO2. And there's functional reasons for that, which we'll get to when we start talking about transblood placental gas exchange. But with respect to your oxygen consumption, oxygen tension, there's a slight increase in oxygen tension, so oxygen content of blood, and your oxygen consumption increases by about 15 to 30%, depending on what trimester you're in. The acid-base changes, your pH is slightly alkalemic with that elevated PO2, but that's largely due to the reduction in CO2. And that respiratory alkalosis occurs very early in trimester 1, probably as a result of increasing progesterone being produced by the corpus luteum of pregnancy that enhances your oxygen CO2 sensitivity of the brainstem. So you're wanting to be a little bit alkalemic from your chemoreceptors. With all of that extra alkalosis, your kidney actually starts to retain chloride or excrete bicarbonate, and this hyperventilation will also cause metabolic alkalosis, which will favour gas exchange at the placenta in the same way that our oxygen is. So the shift in the ventilation PaCO2 curve will increase as a result of the increased minute ventilation of about 50%. And that's divided into our two sections, the tidal volume, which goes up by about 30 to 40%, and your inspiratory rate, which goes up by 10%. And those changes peak at about 24 weeks, which is about the time of viability of the fetus if born in the wild. And we can keep a baby alive born younger than that, but it's rare in the wild that a fetus born younger than that will survive. So the changes peak at about the time you can actually deliver a live born baby. So the increases in tidal volume is a function of the relaxin hormone, which is also produced by the corpus luteum, which induces soft tissue ligamentous change, allowing some of the rib angles to flatten out. So the little tiny ligaments at the heads of the rib soften, and that enables the rib cage to bucket outwards so that the both the AP diameter and the transverse diameter of the chest wall increases by about 2 to 3 centimetres. And the overall circumference increases by about 7 centimetres. So the rib angles have changed from 70 to 100 degrees. So you can imagine that it's like the rib cage of the woman is splayed out and open, which makes sense because she's got a gravid uterus that's gradually going to push all of her abdominal viscera up into her chest cavity. The diaphragm goes up by about 4 centimetres, and that has effects on reducing your residual volume and your expiratory reserve capacity. So the overall effect is one of a reduction in your functional residual capacity by about 20% when you're standing and about 30% when you're supine. And that can actually be above the level of closing capacity. So pregnant women, when lying on their backs, even without the effects of the aortic cable compression, can desaturate because they've got beyond closing capacity. They're like little old men in bed. The total lung capacity is about the same or only reduced by about 5%. Because of that enormous increase in AP diameter and transverse diameter, you don't lose a great deal of total lung capacity. Your lung compliance is, however, changed. The chest wall compliance is somewhat reduced because the rib cage is already splayed up and out, so there's not a lot of extra compliance it can give you. So your residual volume goes down by about 20%. Your expiratory volume also goes down, so you get less FRC, but your inspiratory volume, reserve volume, goes up by 10% because of those changes to the rib cage. Your vital capacity and your forced expiratory volume in one is usually unchanged, and there's no change to lung compliance. The other thing that women often talk about is nasal congestion and obstruction in their upper airway, and that's also a function of the sort of venodilating effects of progesterone. So if we think about some of the anatomical changes to the airway, you've got mucosal edema secondary to fluid retention. You've got a mild increase in your anatomical dead space by about 45%, largely in the conducting airways, and your airway resistance can go down due to large airway dilatation. You can also get engorgement of your nasal mucosa and your vocal cords, and that can increase airway resistance. And that's one of the reasons why pregnant women can be slightly more difficult to intubate. And then finally, during labour, this all can go up again, up by another 70 to 80%. And that's something we'll also see in cardiac output. So throughout the process of pregnancy, we've gone up by 50%. And then in labour, we can go up by another 50%. And your oxygen consumption also goes up by 60%. And that usually normalises after about 48 hours postpartum. So to summarise that, minute ventilation can increase 70% during labour, which is comparative to the increase in cardiac output during labour, which is 60 to 80%. And with uterine contractions, increasing oxygen consumption by 60%. And that's it. Those are largely the changes of pregnancy. So when you think about it, you think about an increase in alveolar ventilation or minute ventilation made up of an increase in tidal volume and respiratory rate. You're looking at an alkalemic respiratory blood gas with a slight elevation of PaO2. You're looking at a softened and stretched chest wall cavity with an increase in tidal volume and over the period of time an increase in respiratory rate. And you're looking at the effects of progesterone and relaxin on various ligaments throughout the respiratory system. The reduction in FRC via encroachment on your closing capacity, so a reduction in your oxygen store. And those things become important when you're looking at both peri-intubation but also positioning, particularly when a woman's lying flat on her back. And that's it for the respiratory changes.
Thanks, Mike. And I guess the other way to divide them into anatomical changes and physiological changes. So some of the anatomical changes, as you described, within the airway and or in the nasal mucosa.
Yeah, that's right. You should practice writing the change, how you can try and remember all of the changes, whether you do that anatomically or whether you do that by trimester or whether you do it breaking down each section. As long as you can remember to get most things, particularly for, say, a short answer question where we'll often ask what are the respiratory changes and just expect you to regurgitate the lot. We've sometimes asked a question, compare the difference between a pregnant woman at term and an obese person. And there are some similarities and there are some differences. But yeah, you've got to be able to contain the wide number of changes that occur. And it's about 1.5 pages to 2 pages of writing, which is about what we would expect you to get down in about 8 to 10 minutes in a short answer question.
Great. So that's the end of our today's primary snippet. We'll be back with another snippet in a week's time. Till then, goodbye and have a nice time.
See you later. Thanks, Swapnil. Bye.